Good evening. Welcome to the North Broward Hospital District Board of Commissioners Joint Conference Committee. Today is Thursday, December 14th, 2017. I'd like to call the meeting to order. So, Jenny, would you please do roll call?
Roll call, Commissioner Rocky Rodriguez, Chair.
I'm here.
Commissioner Andrew Klein.
Here.
Commissioner Nancy Grubrow.
Here.
Thank you. All business. Follow up on provisional membership category. Who's, is that Dr. Westphal?
Yes, thank you, Commissioner Rodriguez. I'd at this point like to defer to Amy Galloway and Dr. Jensen, who have been involved with the bylaws revision. Let them discuss it a little bit further, and if there's any additional questions beyond the time that we spent last time discussing it, we'll take the time to discuss it now. Thank you.
Dr. Jensen, did you just want me to summarize?
Yeah.
Okay. As many of you know, as you sit on bylaws or on MEC and then follow the progress, as well as our commissioners who sit on the joint conference meeting, we've been working for about a year on some bylaw amendments with General Counsel after the joint conference meeting of 2016. And we have 4 or 5 amendments that have gone completely through the bylaws, the joint conference process, if there aren't any questions here, as well as the MECs. In summary, they deal with some cleanup of temporary privileges to make sure that those bylaws are consistent with the Joint Commission standards and also consistent with implementation processes. We also, put my glasses on to go to the second page. We also, I'm going to talk about the substantive differences in a second. We also have streamlined the process for provisional, where we used to have provisionals automatically come through for, let's call it, a second look at the end of the first year. And we've eliminated that process so that our provisional term is the same 2-year term that we use for all of our other categories. We also did a little bit of cleanup there where we made it clear that a provisional must also complete their initial FPPE and how that FPPE process dovetails into their qualification to be elevated, for lack of a better word, to a different category. So those were not substantive, those were more cleanup and streamlined. We also approved a new bylaw, which essentially allows for medical scribes, and we utilized best practices to set forth the criteria as to when a practitioner, only a physician, can utilize a scribe, and then what are the appropriate requirements both for the scribe and then also for the practitioner. And it's a real-time process, and that's all set forth in the backup of the scribing. And then the last thing that we did, no, that, excuse me, is that what, the last thing that we did was we stopped and started on an expedited privileges process that essentially trying to take a change in the 2016 the Joint Commission standards that makes a differential between temporary privileges, which should only be utilized rarely and for need, as opposed to expedited privileges, which are really more, think of someone coming right out of residency, coming right out of training, squeaky clean. So we had that expedited privileges process before it went all the way through bylaws, it went all the way through joint. There was a little bit of pullback along with these other ones that I'm mentioning to you to make sure that General Counsel and Special Counsel, Ms. Rodriguez, bless them, so to speak, from an administrative and from a system perspective. That's all been done. So the ones that we're bringing forward now for sort of a final blessing, there's no controversy, there's no dispute. There's a couple that got left on the table, and you know, for full disclosure, that bylaws may or may not pick back up, including medical students charting and whether or not temporary privileges in some form or another should be available to our mid-levels. But we wanted to go forward and get the rest of these that are really cleanup and improvement type bylaws out to vote as soon as we could. So we're bringing them back to you tonight, informational, and also on expedited, we do need an approval because we have not had that substantively approved here.
Just to clarify, if I may, the thing about the provisional category is it will be for the provisional status, it will be for a term of 2 years. Now, just because you have adequate encounters that makes you eligible to become active at the end of the first year, that doesn't become automatic. The practitioner has to be responsible for making that request, just to clarify that. Yeah, yes.
Dr. Jensen, do you have anything to add?
The only additional issue is whether or not we're going to address medical students writing in charts. And, on the medical side of the equation, we've had discussions at the bylaws committee, and obviously it affects mostly Broward General in regards to medical students writing and charting, although we do have issues at other hospitals where students are rotating through surgery services and such. ER services and such, and who's writing into the chart. We find it ironic that we are allowing medical scribes to come in with no medical training and taking a course that can write into our charting system, but yet a school-sponsored medical student, third year, fourth year medical student is not allowed to write in our charting system. Our current charting system, they write on blue sheets and put it in the back of the chart. They get thrown away by medical records. So we still feel strongly that medical students should be allowed to write into the charting system. However, as we progress away from paper system and we're going into electronic media, it may become a moot point because then we're going to start having to address the issues of how we're going to handle who's got access to our electronic health records and the chart dictation system and who's addressing that right now. And that's something I think as a system we need to be addressing on how we're going to handle medical students and our residents. Obviously, we know it, our general residents are certainly charting electronically into the systems, and co-signing happens at the level of the doctor. But whether or not we're allowing medical students to then get into our EHR and do that, we'll have to address. So I think for the better purpose, until we make a decision system-wide, I know there's been some discussions amongst the CEOs in regards to forcing physicians to go all to electronic notes, because we're not at that point right now. I don't know what the penetration is right now of physician writing notes into the system, but we still have charts everywhere. So I think as we decide as a system to move electronic for all our noting, we have to make some decisions on that aspect. So I think in betterment, we'll put the students writing in the charts on the table for further discussion back to the bylaws committee before we make any recommendations for the joint to approve here.
I'd just like to add, could I add one thing, Richard? One thing, I think that there probably is likely a solution out there that other hospitals are using, an IT solution, and I suggested before we bring that back that we do some investigation in terms of seeing best practice.
Absolutely.
Because there's some best practices out there. The one thing we want to stay away from is making sure that those charts can't be copied and pasted. That's the big issue right now in my mind. So I think, and also having a separate section. So I will work on that with IT and see if we can come up with a solution, unless Paul's got a suggestion here.
The solution is ready.
Okay.
Whenever the bylaws are passed.
Okay.
It's already been built.
Okay.
The solution ready for medical students. I know this discussion started years ago. It's been ready, we're just waiting.
Yeah. I personally would like to see a demonstration of that, and I think probably a lot of other people would too, at the respective MBCs, to get a feel for that, because eventually we're going to have students in all the facilities. So,
Just like the resident.
yeah, I'd like to take a peek. What prevents, and Paul, just a question, what prevents someone from copying and pasting a student's note?
We can turn that preference off.
We've got to do that, because that's, I don't have a problem as long as it's in a separate section of the chart, as long as it can't be copied and pasted. I don't have a problem with that. And that's been my major concern all along.
It can be stored in a separate section, just like Dr. Jensen mentioned, the paper documents,
Mhm.
scanned.
Okay, great. Then obviously I withdraw my comments about looking for a solution since we already have one. Thank you.
Yeah, but we still have to, we don't have a provision for that right now in our
Right.
bylaws
Yeah.
that reflect that
I agree.
privilege.
Yeah.
So when we make that decision and do it
I
through the
agree.
Cerner system, we certainly will just make an amendment to
Mhm.
the section in our medical students and the GME section in the bylaws has to
Okay.
be amended for that.
Mhm.
We can certainly bring that up at another meeting.
I agree.
Okay. Temporary privilege. Dr. Westphal, you know, has that,
We already, I think Amy already addressed the temporary privileges.
okay.
Do you want to say anything more about the temporary privileges?
No, I just think we need a motion to either approve them all as they've been cleaned up, or at minimum to approve the expedited so that that can go forward.
If I could ask a question. I barely know where I am yet, but I need to ask a question. I see a document that's entitled Temporary Privileges. Where is provisional membership? Is that within this?
Yes.
So all the things you're asking us to vote for are in this document?
Yes.
Yes.
Yes, those are the proposed, that's the proposed language of the amendments. Page 3.
I think there's always confusion on semantics in regards to what we consider temporary privileges, what medical councils were using the verbiage of temporary privileges was somebody that went through C&Q, had been approved by the medical staff at the local level of the hospital, but then had to wait 2 weeks to get them processed to the board level for approval, and people used to call that temporary privileges. That's really not temporary privileges. So everybody was using the wrong verbiage when they were presenting to the board at that aspect. So temporary privileges, we just had a hurricane come through. We need medical staff urgently, somebody that's not on staff, then we have to get that person into the hospital, make sure they're safe to come into the hospital, work in our system temporarily. There's this time limit, fixed limit, but they don't have to go through a 4 to 6 month process of getting certified to be going through the process that we normally do. And that's done at the local level at each hospital, but there's a system, that's what these privileges here are trying to discern. And the expedited privileges is the section, the other section in the back that now we want to let physicians that have a clean slate come before their MECs and then have a short meeting with some of the Board of Commissioners to then get that process done early instead of waiting the 2 weeks for privileges.
And you as a body think that this is in the best interest of the public and your staff?
We have been doing this for absolute years. It's just cleaning the language up so everybody is same language across the system.
Thank you.
Thank you. Dr. Westphal,
I think Commissioner Rodriguez and I had already discussed having 2 or 3, probably 2 board members that would then go over the new clean applicants the day after MEC for approval. And we haven't really detailed that, but that would be the idea. Once the MEC approves them, and before it has to go to the full board, then what we would do is get those approved. Sometimes it can be 2 or 3 weeks early, so we get the position fully on the staff. Where they're fully on the staff, they're not temporary, because temporary has to be eventually approved within, I think, 90 days.
rather than vote at this meeting, is that what you're saying?
Right. It would
Well,
be-
here's one point that I want to bring, especially for the benefit of Commissioner, and some of us, like Commissioner Client and Commissioner, next, I'll call you that.
Gregoire.
Okay.
It's a hard.
I know, but anyway, I know that we received the agenda, but is there any way that we can get some of this information, like a little bit earlier, before the meeting, so we get a chance to review it before, so it would make it a lot easier to come in already with the information, and if we had any questions, we can always call anyone on the staff to help us with this stuff. So your recommendation is that we hold off on this until we review all of this again?
I don't know that that's really necessary. We've discussed the expedited privileges in the previous joint conference committee, so I think people have a clearer understanding of what we're doing, and I think we ought to move forward with it, because that, I think what would have to happen, and I stand corrected if I'm wrong, would be that we could approve it here, then it would go back to the MECs, because it hasn't gone to the MECs yet.
Oh, but it needs to be approved here
Well,
before it
we
goes
prefer it.
to
It
the
doesn't
MEC.
absolutely have to. It could go back to the MECs, but it would be nice to have a show of hands to approve it.
Okay, so, if anybody wants to,
Dr. Westphal, this has all been approved at NBC level.
Yeah, the expedited too.
Yep.
Have the expedited been
Yes.
approved? Okay.
We've all, MECs have approved.
So then we
expedited
really don't
privileges.
need to have a vote on it. This is just for discussion and clarification.
It's for
Right.
discussion, we can
Okay.
go for the vote, but as you see in this package is the clean version of what
Okay.
we're discussing.
Okay,
The
good.
bylaws,
Great.
unified and bringing to joint, and MECs have all vetted this information at the local
So
level.
as long as the expedited was included, I did not know that. I knew
So
the
that
rest
what we
had
do
been.
is vote on this today as an entity for changing the bylaws, then that goes out to vote to all the medical
So
staff.
this is really not for approval. This is to now have any further discussion, so this can then be mailed out.
Yeah, so this, once we approve it here, then this packet gets mailed to every medical staff member in the Broward Health System for them to vote on and
Okay.
ratify that as the new language. And so they all understand what those changes are. Because this
So-
really just affects
so
medical
we
staff.
still have to approve it here today.
So we approve it here, then we have to send it out for vote. We send it out to every single medical staff member that has voting privileges at their
Well,
specific
additional
hospital.
review. Okay. So do I hear a motion to approve?
Well, I just, Mr. Chairman, I have a couple of questions with regard to the, particularly with regard to the expedited privileges that are addressed in the back of this package. What's the time difference between an expedited privilege process and a normal process?
Probably about 2 weeks, because it's, medical executive committees usually meet the second Tuesday of the month throughout the system, the 4 hospitals. So the board meets the end of the month, so it's usually a 2 to 3 week window. So those people that have been approved by credentials and then approved by med exec have to wait till the board meets, which is the 2 to 3 weeks. So if 2 commissioners got together a day or 2 later, you save them a couple weeks, and they can get on staff and start working right away.
The other consideration, Commissioner, is that sometimes through holidays or other conflicts with your all busy schedule, that we miss board meetings, and then our applicants, our clean applicants that would otherwise be available for expedited, can't come on staff. So that's another reason why expedited is an appropriate process for those qualified applicants.
Okay, and it appears that there's 2 different categories of those who would be eligible for expedited privileges. And my question, is the modifier at the end, does that apply to both categories, where it says that they've been presented to the Credentials and Qualifications Committee with complete applications? That would apply to both categories of those who are eligible for the expedited privileges, not just the second of the 2 categories?
Yes, that applies to both expedited and temporary.
Okay, now I'm talking specifically about section 4.4. Expedited privileges are available to practitioner or licensed independent practitioner applicants initially seeking employment and to practitioner licensed independent practitioner applicants who currently hold privileges and then present to the Credentials and Qualifications Committee. So that
Yeah.
presentation part applies to both of those prior categories, correct?
Yes.
Okay.
Yeah, that's, as you know, when you apply to a hospital system, you mark how many hospitals you want to apply to, but you go through one primary hospital as your primary hospital. You declare as a physician which hospital you want as your primary. So like I'm on staff at Imperial Point in North Broward. My primary is Imperial Point, but I had to go through the credentialing process at both hospitals. And so if I'm currently wanted to get on staff at Coral Springs, my 20 years tenure at the other 2 hospitals, and then I would apply to Coral Springs and they would say, he's clean, he's got no issues, we know everything about Dr. Jensen, let's expedite him, if I so chose. Most of the time, it's not an issue, but sometimes when we have large physician groups where they've had a change in their personnel and they historically haven't been coming to a particular hospital, now they need coverage issues, that helps that physician group out for expediting privileges if they have a sudden loss. We've had deaths in physician groups and things that we need, some quick coverage for. Not everybody meets these categories. These are very specific, very specific things that get vetted at the specific hospital level where we know these physicians very well.
Okay, so,
Okay, and they, and all three of those criteria would have to be satisfied that are stated there?
Correct.
Okay.
Yeah, it's a three-layer process before it even comes up to the board.
Okay.
Okay, and then, once those expedited privileges are granted, that would still come to be recorded by the board as something that's already been approved?
Correct.
And it would be confirmed by the
That's
board?
correct.
Yes.
Okay.
That's correct.
And the other question I had was relating to medical student charting. That was mentioned in the presentation, but I don't see it in the bylaw packet here. Am I missing it, the language on that?
You're not missing it. There was some questions and concerns on the part of, as expressed by Dr. Westphal, and so there wasn't a consensus with General Counsel and the Bylaws Committee on whether or not and in what form that should go forward. So that will likely be an effort that will be picked back up, particularly if we have IT confirmation that the concerns of cut and pasting are addressed. I think that Dr. Jensen accurately expressed the desire of at least a couple of the facilities that we would like to have medical students charted, but that is not in your packet and is not present for approval this evening.
Okay, so we're acting upon items 1 through 4 under the follow-up discussion under old business?
Correct.
Not item 5?
Correct.
Okay. And the on-call policy and the contracts will be discussed separately? That's not the subject? Okay.
so we want to vote on it, correct?
I guess I just have one more question. You don't see expedited privileges as the exception that's going to swallow the rule, do you?
No.
You would, this would be
Expedited
rare.
privileges are really for just really clean candidates. You know, people right out of residency, they have no malpractice issues, they have no quality issues that we have to research at past employment.
Thank you.
There's a very narrow scope of who actually needs expedited privileges. It's the exception, not the rule.
It's also based on the need. It's based on the need too, if we, as Dr. Jensen said, for coverage.
Thank you, Alex. So we had a motion.
Yes, motion to approve,
Items 1 through 4, Gary.
yeah, items 1 through 4 and pages 1 through 6 in our packet.
Okay. Do I have a second?
Second.
Dr. Joe, good afternoon, sir. All right, any discussion, any questions, any further discussion? Having heard none, Jenny, would you please call the roll call?
Commissioner Rodriguez,
Yes.
Commissioner Klein,
Yes.
All right, let's move on, new business. Did I miss anything?
Yes.
We're all voting members,
We're already members
so you
on this
need to
committee.
call the roll of everybody on the committee.
Or you could
Apologize.
just, who votes no? And make yourself known.
I'm trying to get my way around it. All right, go ahead. Do you want to do the roll call of the doctors?
want to do it all together or separate?
We can do a show of hands.
You can say your name and vote your yea or no. If you want to just say your name as a voting member.
I believe that would be a good idea.
Want to start? Dr. Penate, want to start?
Dr. Penata, yes.
Dr. Penate, yes? Dr. Boyer, yes.
Dr. Starr, yes.
Dr. Zingaro, yes.
Dr. Larry, yes.
Ladies and gentlemen, I'm not a voting member, but today I was given authorization from Forest Chief of Staff, the voting members, so yes.
Sunil Kumar from Broward Health Medical Center, yes. Michael Morris from Broward Health, yes.
Dr. Yogo, yes.
Susan Newton for Rehab, yes. Alice Taylor for Broward Health North, yes.
Alberto Casaretto, yes.
Howard Lukowitz, yes.
William Jensen, yes.
Other voting member?
Sandra Todd Atkinson, CEO over at the Medical Center, yes.
David Drobo, RMO, Broward Health Medical Center. I don't think I'm a voting member.
You are now.
Am I a voting member?
No, neither am I.
Unless you're designated.
You're right.
Having heard a unanimous consent, the resolution is passed. So, did I miss anything in all business?
Yeah, the on-call policy contracts.
Okay. On-call policy. Is that you, Mr. Santorio, or?
It can be me, it can be medical staff. You want me to talk about it, the on-call policy?
Sure. I mean, this was a policy that was already passed at the board, but the medical staff has a lot of issues with this policy. And I've discussed this with Gino, and evidently he told me he was going to bring some changes to the policy.
Yes.
And so I'll let you go ahead and present that.
So there are some changes to the policy. I believe that's in the packet here. Wanted to review this with the joint conference members here. The changes that were made, so one of the concerns of the medical staff is that chiefs of staff in particular were not named in the on-call policy that we have drafted and approved through the board. So we wanted to make sure, in practice, we are certainly seeking out medical staff input, but in policy, it doesn't reflect that, and it should. We agree with the medical staff. So we made a couple of changes, which are really only on 2 pages. The first change is under procedure, page 2 of 8, and it defines here the call management team, and then states that in consultation with the chiefs of staff, legal and compliance. One of the
Well, it's not on this copy.
This isn't the draft version. So one of the concerns with that, and it was a good step forward, but medical staff at Broward Health Medical Center, do you have the contract? Can I?
Mr. Chairman, can we also request that the physicians be given copies of the packets a little bit ahead of the meeting to review, just like you all have?
Yeah, absolutely. I believe that we're all sitting at the same table.
Because this is the first time I'm seeing this.
Yeah.
It's difficult to digest in a few minutes.
Yeah, so one of the things I wanted to bring in, again, this is the second meeting we've had in 2 years, right? We've had them back to back. My commitment, the chairman's commitment, and what seems like the medical staff commitment is that we have these every month. So as we move along, we need to have a little bit better process of communicating some of these things. So for example, this draft policy came to me at 4:59 on, when was that, Tuesday? On Tuesday, so I brought it straight to the Medical Executive Committee at Medical Center. But what I want to do is distribute this to all the medical staff and get input so that as I get input from medical staff, maybe through a singular point, probably Amy or a representative that you choose would be better, to send to me, I can try to get that approved. But just for some feedback, because there really are only 2 changes in this draft version. The first change is under section 4 procedure. It says, in order to meet the needs of Broward Health patients and to comply with applicable regulatory requirements, the Broward Health Chief Medical Officer, the Regional Chief Executive Officer for the applicable Broward Health facility, and the Regional Medical Officer for the applicable facility, defined as the call management team. And then it says the change is we added in consultation with the Regional Chief of Staff for the applicable facility. One of the requests, just off the cuff, that Medical Center made in their MEC was that they would prefer to see, instead of in consultation with, they would prefer to see the Regional Chief of Staff for the applicable facility included in the call management team. And I spoke to legal and compliance today. They are supportive of that. So if, I know this is short notice, but if everyone here agrees with that, what I will do is before sending this version out, I will have that change made and then send that updated draft out to all the medical staff. I want to forewarn you, that will trigger an additional change, and the reason is the call management team in the current version is responsible for a couple of things that you don't want to be part of, such as writing the business justification for the fair market value, compiling all the information and sending it out. So they're just going to adjust that and then send it back out. And really the only other change in this entire policy, which will again be changed with what I just discussed, is on the next page under A, it says if the call management team, and then it says comma, in consultation with the chief of staff, same thing under number 2 below. So that'll go away because you'll be in the call management team, you being the chiefs of staff. So those are the changes that would be made in draft format and sent out to all of the, I guess what I would like to do is send them out to the chiefs of staff, the vice chiefs, and the CMOs of the facilities, and then whatever information is compiled from that, the comments can be distributed back to me through a singular point, whoever that is.
Mr. Chairman, can I say something?
Yeah, go ahead.
I just want to, for the record, first of all, I appreciate you bringing these changes and responding to, to this, but I just want to be in the record that basically we made these requests for 2 reasons. Number one, the original call policy that was approved was in contradiction to our bylaws. So, we do have bylaws for a reason, as I talked about at the last joint conference. So that was one of the reasons. And the other reason is probably the best reason. It's a matter of patient safety. Because when you're dealing with, and we've had several incidents even recently at Broward General, when you're dealing with who's going to take the call and who's going to be responsible for taking care of the patients in our community, there's no better person or people than the medical staff or chief of staff or his designee or the department chair to make that determination of who's qualified to take the call, particularly at Broward General, North Broward, that are trauma centers. So I think for the record, the issue of patient safety in reference to this call policy, and including the medical staff, is really of utmost importance.
And we agree, for the record.
Gino, is there any consideration to not only including the chief of staff, but also the department chair in the management committee?
We did think about that, but what we thought would be better, in case there were conflicts of interest in certain areas, were to leave it up to the chief of staff to include those individuals. So we went silent on that. Doesn't mean that they can't. In fact, they probably should. I mean, as an example, as a point of reference that you just gave, that both trauma department chairs right now are involved in developing the quality metrics for trauma as we speak. So I think in most cases it's going to apply, but we wanted to leave it up to the chiefs of staff since they're the most they would be the most non-biased.
I mean, I'm happy with chief of staff or his or her designee, wherever. Yeah, however you want to word it, but as long as the medical staff's involved, it's important.
How about chief of staff and at his discretion, the department chair, so giving him or her the option of including another member of the staff?
So we can bring, I guess what I'd like to do is, if that's a recommendation, I'll compile all the recommendations and then bring them back. So I'll send out the original, if it pleases this group, I'll send out the updated draft, which includes the chief of staff and the call management team, and then I'll compile all the recommendations that come back so we can make the changes all in one document and then send it back out again to bring here.
Yeah, go ahead. Hold on, Dr. Singara, please. I have
Including the department chair, maybe a little cumbersome, but if you have chief of staff already in the process, they should be responsible for talking to the appropriate department chair to decide who should be taking call, because if I am the chief of staff in the Department of Medicine, I may have nothing to know about about Department of Surgery and a specialty field. So the obligation comes to the chief of staff to talk to the particular department chairperson to see whether the person taking the call is appropriate or not.
So I should point out, and actually I just remembered this. So adding the chief of staff to the call management team gives you that authority. It essentially gives you his or her designee, because when developing the quality metrics, it states that the call management team and anyone else they want to include. It says something like that in there. I'll pull up specifically what it says, but
What section is that?
I mean, I don't know if I have it.
While Gino's looking for that, I'd like to just ask a question about where the process as proposed leaves us. Since this on-call policy has already been approved by the board, that policy would remain in effect pending the changes going forward. Is that correct?
Can I address that?
Yes.
Because I was at the board meeting where you did approve and there was the caveat by several of the commissioners after their comments were that this was a living, breathing document, basically, that was subject to amending that whenever. So I would suggest that, Gino bring the changes, the proper verbiage, and get approved by each MEC, and then bring it back. You can bring it back to the board and amend the policy, I guess.
And that's my concern, is one of timing, how quickly we can get these changes done and then brought back and implemented in the new policy if the current policy is not universally satisfactory to everyone. So, I think we want to talk about what type of time frame we want to be operating under to get these changes implemented and adopted at a future board meeting.
Can I make a comment? We're also going to have to sit down with the bylaws committee and make changes in the bylaws if this is adopted by this committee, because in the bylaws, it's been, as Dr. Yogo has pointed out, that this is other policy that's in the bylaws regarding on-call and who determines on-call. So this is going to require a change in the bylaws. So when Dr. Jensen calls the next bylaws committee meeting, we'll have to seriously address these changes if we're going to incorporate it into the bylaws. So, and while I have the microphone, I just had a question about the minutes under new business on call policy. Oh, I'm sorry. Okay. Okay, it had to do with on calls.
Mr. Chairman, can I make a couple of comments?
Go ahead.
Again, I'm Dr. Sunil Kumar from Broward Health Medical Center. I wasn't here in the last joint conference meeting. In the last few months or years, especially for the new commissioners, first of all, I think everybody sitting around this table today, our intention is the right one. I don't think anybody has any bad intent. But I feel like in the last few months, we have had some disconnect in communication. I think if our intent is good, the best way to build a system, to build a hospital system, is you as a supervising or the body that oversees healthcare in Broward Health, work very closely with the clinicians who are in the trenches taking care of these patients. When I say that, Dr. Yogel mentioned earlier that patient care and patient safety is our goal. Who else knows who are the best physicians, who are the best clinicians other than the physicians themselves? We put in a lot of hours and minutes in this hospital system, looking at credentialing, looking at reviewing their charts, reviewing their records. We go through the FPPE, OPPE process. So we know who is good and who's bad and who's ugly. It's not like we have a crisis here that we have to change everything around. We do have a good system in place between your rules and regs and our bylaws. I think we have a pretty good system. Do we need to fix some of the language? Do we need to fix some of the issues that we have? We do. We definitely do. But other than reinventing the wheel, I think we should have a communication process. I can assure you we will work with you because I think our goal is the same. I really want to see the system working and doing very well because this is the only place that I come to work. And I've been coming here for 20 years. So I think we need to keep an open mind and let's work together on this. Going back to the on-call, the bylaw clearly states how the on-call process should be done. And I don't have anything totally against this process either. But I don't know if this was done for regulatory reasons, could be a business reason, which is fine. It is a system, the system has to run fine. But I think we should probably engage physicians and clinicians as part of this moving forward. I think we can do a better job. We don't have to go back and clean up the dirt that we create. No offense. Thank you.
Thank you, Doc. Anybody else?
Yeah, can I make a comment on the on-call?
Yes.
This is Alberto Testred, I'm the Regional Medical Officer at Imperial Point. So I just wanted to, just sort of implementation-wise, have just a discussion about, once the call coverage has been decided upon, the schedule, which means who's going to be doing the call. The call schedule is basically going to be, once we've decided the call, then you're going to reach out and see if there's employee physicians, and then if there's a need for community physicians, so we're going to post that information out for community physicians, and then once that occurs, the qualifications of that individual physician are going to looked at from a clinical standpoint, and if they're qualified, then they will be put on the call schedule. So I think there's some confusion as far as what other things maybe the call coverage management team could decide, and that's where it's more of a quality issue and not so much of only physicians that have offices close to the hospital or only physicians that are primary at a particular hospital can do a call schedule. There's some confusion as far as what could be decided on the call coverage management team.
Can I answer?
Go ahead.
So I found this section, and it speaks to this answer as well. So it's on page 4. It's call coverage panels, including qualified community physicians. And on page 4 on the bottom, it talks about the call coverage management team shall maintain a current list of Broward Health system-wide specialty-specific criteria developed and improved by, at a minimum, the Broward Health Chief Operating Officer, Chief Medical Officer, and Regional Medical Officers. I would advise medical staff, I would think that that would be one of the areas where you would want to include yourselves in there. In the draft agreement, we did include medical staff, but I want you to look at the language in that. And then it says after consultation with legal department and compliance. So what we're doing here, and Dr. Kumar, I understand what you're saying. The medical staff does know who's quality and who's not. The problem is we can't say that we think a physician isn't, and I'm not saying that you're saying this, but we can't say that a physician is poor quality and so they can't take call. They have to be poor quality through peer review, which means then they're restricted or they're not credentialed. There has to be action documented through it. And the problem in the past is at some locations there hasn't been. So what this is going to be, and I'll give you an example of what we're doing right now, trauma, we're looking at creating ortho specialty. So right now, there are no specialty specific criteria in existence for the facilities, okay? So that means if you're credentialed in the specialty and you're credentialed to do it, you're allowed to take call if there's a call need. Going forward, as we start adding things, one of the things that Dr. Westfall's been very actively involved in with the 2 trauma centers and all of the physicians that are our medical staff there is what additional things do we need? So for example, do we want everyone who's credentialed to do orthopedic surgery to also be able to do trauma surgery? Probably not. We'd like them to have a certain number of CMEs for trauma. We'd like to know that they've done a certain number of long bone fractures, right? So we're coming up with those, and as long as, and the reason why it's in consultation with compliance and legal is, what we're looking for is, to your point, we don't want to make sure, we don't want it to be on who's admitting or who's got an office near us. We want it to be on things that are very specific to patient quality. So, and I could not agree more that medical staff, they're the ones who know what needs to be done in there. They're the ones who need to contribute to this. And going forward, to your point, that's exactly what our intent is. You know, maybe it wasn't done the best with the call policy, but I hope that everyone can see that going forward we are doing that. We're bringing things, we're changing things. One of the things on the agenda today is for suspension. I'm walking through everything. We're not making a single change that affects the medical staff without involvement of the medical staff. I think we were all on the same page there.
So just to be clear then, so you're saying it is, the decision-making on who's going to do call is a quality thing, and
Yes.
it should be through peer review, but it should not be, okay, well, you know, in this specialty, only the primary physicians that are at this hospital can do call, or in this specialty, physicians that have offices close can do call.
Correct.
I'm just trying to make sure we're on the same page.
100%.
So that shouldn't be happening at the individual institutions.
Absolutely not.
Correct.
I think the seminal word is qualified.
Yeah.
Qualified.
And I hope it's not.
I hope that's not a problem.
Mr. Chairman, can I make a
Yeah, go ahead.
You know, the only other issue, and I know we're kind of revisiting something that we've already been passed, but like I said, my own feeling is that it should not have been passed, because I feel it was misrepresented to the board when it was voted on. You know, the section under the policy that says that the call coverage will be provided exclusively by employed physicians, which to me, you know, to me, back when it was a couple years, 2 or 3 years ago, when Dr. El Sanati was around still, and we had a joint conference, and the board specifically opened up the call schedule at the time because it was felt that that was actually a violation to close the call schedule and have exclusivity to certain physicians. Might have even been a compliance issue, a compliance violation, OIG, whatever you want to call it. But yet that's kind of what this, maybe you can explain to me why it's still exclusive to employed physicians, and what is the definition of an employed physician? Does that just mean if I'm private practice, but I have a contract for the emergency room, does that make me an employed physician, or do I actually have to be a Broward Health employee to have priority in taking call here?
So I'll take it in reverse order. So an employed physician is, you actually have to be a Broward Health employed physician. We have about 100 of them. As far as the compliance issue to close and call, there is a compliance issue there that I'm aware of. I mean, I wasn't here, I'm not sure what the specifics of it is, but there is an issue. If you were to close call in a particular specialty to a certain group, that is a compliance issue. And this, if you were going to, let's say we were going to close orthopedic call, and we were going to close it to a group of 3 orthopedic physicians, but there's other orthopedic physicians, none of them are employed. That is a compliance issue, that's a problem.
Excuse me, you got it all figured out?
You got it? Yeah. Okay. That would be an issue. It's not an issue when you close it to employed, because that becomes a business decision. So now to your question, why are we doing it? There's 2 reasons why we would do this. One is a business reason, which is we invested a lot of money in an employed physician group. In the fair market value, it includes them taking a certain amount of call. So there becomes, we'd be losing money not to have them be taking the call. That's a business reason. That's not, in my opinion, why I think we did this. And I think if you look at what it actually affects in terms of a change around the system, it's very minimal of which areas it affects. It really speaks to why we did it is more from a compliance reason. So the monitor said we had to have a call policy. They didn't dictate how we had to do it, but utilizing our employed physicians that we already pay for was the most conservative approach to be able to say that we're not trying to incentivize community physicians who can bring referrals here. That's why we did it.
I understand that they have to call, but do they have to do all the calls? Can they? If you close the call, they have to certain amount of calls, so they don't have to do all of them.
Correct. So the specialties that are, what they decide is there a need to reach out and also have community physicians take call? So what that's determined by is if there are employed physicians who, let's say we have 15 employed physicians, there's likely not a need to take call. If there's 5 employed physicians, there may still be a need to take call. One of the things that's really annoying.
Why don't we,
Turn it on.
why don't we each of us speaking, maybe feedback?
Okay. Anyway.
I think here, I mean.
You can hear it, right? So one of the things that Dr. Yogel talked to me about this week was that, isn't it important to have physicians tell you what's an appropriate amount of call? And I think it is, right? So having the chief of staff on the call management team, I think they're going to speak to, hey, look, you have 3 physicians taking call, that's really not enough, you need to open it up to the community. So the chiefs of staff will have input into, do we think there is a need to reach out and also having community physicians take call. For the most part around the system, like I said, the only change that's going to be impacted by this, or has been impacted by this, is the cardiology group at Broward Health Community. Everywhere else, it's pretty much remained the same. Not pretty much, it has remained the same.
I have a question. Why did,
Go ahead.
why did they think that we don't have a call policy and why they think it's not? We do have a call policy.
There was not a system-wide call policy. There was, it spoke to the bylaws, and each hospital was kind of doing their own thing, actually doing their own thing by department. So there's a lot of areas that were not an issue. We want to acknowledge that. There's a lot of areas that did not have an issue with call. But the compliance, the CIA, found an issue with the way that call was done, said that the monitor stated that we needed a call policy. And so we came up with a conservative call policy that we put together.
I think it's important to kind of have a consistent message. And that doesn't mean that the message doesn't evolve and we don't, it doesn't, can't be built upon, but it needs to be consistent. And if I'm hearing you right, putting on my lawyer thinking cap, what I'm hearing you say is that there's an issue if you close call to a certain group or group of individuals, whether it's a practice group or a group of individuals. We understand that because that was the impetus of the meeting in 2016, 2015, and then again in 2016 where we're opening call. Independent of this employed physician issue, and it was fully supported by the medical center. So maybe it took a little longer than it should have, but you saw the development of the...
Can we shut the speakers off? Thank you.
But you saw the development of the call policies for the academic centers. And I don't dispute that there may need to be a systemic or a division between academic centers and non-academic centers, because obviously the residents create issues for call. But there's a disconnect to me logically between the conclusion that you just made, and it's different from what I've heard over the several past months. If the concern is we can't award call to a group because that could appear to be a AKS violation or some quid pro quo, medical staff totally supports that. They don't want that. But at the same time, I don't know that that leads to the conclusion logically or legally that therefore the only route to take is the conservative route, which is, hey, let's not even worry about having to worry about it. Let's just give all the call to employed physicians. It's that step that I think takes it from being, hey, the monitor says we need a policy, to here's our conservative policy that basically takes, possibly, and from this language, wholly if so chosen by administration, takes our community physicians out of call unless you can't service that call with your own employed physicians. Everyone gets the business part of it. I mean, we understand, and there may be full support for that just by supporting the business component. What worries me a little bit is that disconnect in what I just explained. Don't say, well, the monitor suggests the easiest way, which is another word for conservative, is to just have your employed physicians take call if they can. I suspect the monitor might have said that. Nobody's ever provided that to us, but they might have said that. I've heard that, in my own research. But that doesn't mean that you have to do it this way. It doesn't mean that you have to award all call to employed physicians unless you can't meet the facility's needs.
So maybe I wasn't clear, but the monitor did not say that, and we absolutely do not have to do it this way. We chose to do it this way.
Well, you're choosing to propose to do it this way. I mean, we have a difference of opinion of you of whether you can just violate our bylaws without having the medical staff on board for it.
And that's fair.
But this is your preferred and/or, if you believe you have the right, your mandated way to go. And I do appreciate you now us really having this substantive dialogue. Don't get me wrong with that, because I think we can get to the policy. I just want to clear on the record, at least from my perspective, that that's different than this is a mandated policy. Because it's not a mandated policy that we have yet to be presented and understood as a mandated policy.
So you weren't here in the last joint conference, and it's not your scheduling issue, that was on our side. But I did go through that in the last meeting, and I stated that, look, we were required to have a policy. Didn't say employed physicians had to take the call, didn't say we had to do it in any particular way. We developed a policy that we thought was both the most conservative approach, in line with industry standard, and frankly, the best business decision for us. That's why we did it.
I think that's a much clearer statement to my ear.
Yeah. And there is a difference. I just want to clarify one.
And then what's in the minutes.
Okay.
We can fix it.
There is also a different, to your point, what you were saying about, are we going to close call, but then give it to the employed physicians? It is a little bit different because they're employed docs that we already paid for. So the reason you run into an issue with the, when you run into an issue with the closing of call is when there's a perceived, let's call it perceived violation, right? So you're going to close it to a certain group because they may give you what you want, and maybe there's other community physicians who want to partake, but you close them out. When you go to the employed group, yeah, there's definitely other physicians who may be interested in taking the call, but it's part of our business model. I also stated last time, that, just to reiterate again, even though that is the model, we don't have an intention right now, and I can't see one in the foreseeable future, to go out and employ more people. We lose $26 million a year, and this system is largely successful because of the community physician support we have. So, hopefully as we stay here and build our brand, that'll be more evident that that is our goal, that is our intention, and that is what we're going to do. We're going to work with the community physicians because they're the ones who have really supported Broward Health for this long, and we think we can get there.
Go ahead. With all due respect, that's not the message that's getting out there to the community physicians. As a matter of fact, last night I was over at North, and I was approached by a primary care physician who asked me what was going to happen with hospitalists and call, and is there going to be a hybrid program and things like that. We feel where we are at Coral Springs that we need to include the community physicians for obvious reasons. And the numbers out there, we know what's going on out there, so we want participation. We don't have a lot of service lines. We don't feel that excluding community physicians is going to be helpful for taking, I mean, I know you're not intentionally doing that, but to exclude community physicians is not good for patient care. And the language, I mean, just to look at the language under number 3A, it says the call coverage management team shall permit qualified community physicians. So with those words shall permit, it's almost like, okay, well, we'll let you, it's sort of a hard couple of words, rather than will include, something like that, qualified physicians. I mean, it just comes across as like, you're holding, it's not the Cleveland Clinic, all of those physicians there are employed. There's no non-Cleveland Clinic physicians that are working at Cleveland Clinic. So we don't want it to be a Cleveland Clinic. We want input from, and my colleagues can chime in. We want community physicians, primary care physicians being there, bring in consultants. We need service lines where we are, and I'm sure Broward General and other regions need service lines very badly. And so unless, and then when you go out there and you try to get the physicians to come in and say, hey, by the way, we need you, they may turn their back on you and say, hey, you didn't include us in the call schedule. We're not going to help you out. I'm not suggesting that they do that. I'm not suggesting that's going to happen. But you may get that backlash that, you know what, if you're closing it off to us, we'll do our thing,
That's the very reason we're not supposed to be enticing people with calls.
No, I'm not saying you should entice people, but as Dr. Yokel pointed out, maybe the concept of it being open is the word. I'm not saying to entice.
No, and to your point about the hospitals and everything else, I mean, we've had one-on-one discussions about that. We'll have a new CEO starting soon, I hope. That's going to take a little bit longer than the 3 months I've been here, but I give it a few months.
I have a question for Dr. Yokel, and bear in mind that as someone who lived here since 1969, I know that I am proud of our community physicians, and you and I have talked about it several times. And it is important, I understand that all of you have treated this community for years. And there are patients that are alive today, many of them, including myself, because of the good care they received at Broward. Now, every time I use this, like, I tell people, I said, about Broward Health, there's more rumors than Carter has pills. And when I said that, people know how old I am, okay? Because I don't remember when is the last person that bought a box of Carter's pills. But one question I have for you, because I'm one of those guys that if there's a rumor mill out there, I want to put it to death and immediately. And if you recall, at my first meeting on this board, back in 2013, I opened my grand opening by putting some crazy rumor mill out of the ballpark, because he was vicious, he was mean, and he was mean-spirited. Okay. You mentioned that it was misrepresented to you at the last board meeting. So, if that's a perception, because I recall, Gino mentioned the fact that it was a policy decision, it was a business decision. You know that you can't blame everything on the CIA, and he's brought up a lot of good points. So if it was misrepresented, and how was misrepresented to you or to us? I like to,
I can address that.
Okay.
Sure. And, with all due respect, I was at that meeting, and the statement at the board meeting was that the medical staff had total buy-in. Everybody, every concerned party involved in the call schedule had total, I think the term was buy-in. Well, that wasn't true, Commissioner. I mean, basically, there's no mention of medical staff in that policy that was passed. I don't think that anybody at any medical staff at any of the hospitals would have had buy-in to that. So we discussed it at the last joint conference, we discussed it many times, and we left it as an open item. We never felt that it should have been presented to the board for approval at the time. And when, and again, chief of staffs are no longer able to even address the board for something, but that's another issue. But in my opinion, it's my opinion that it was misrepresented to the board, and they passed it, and it was represented as having total buy-in from everybody that was involved. And that's not, it's just not true. So, you know, can't lie.
So I want to thank Dan Lewis for filming it, because I'll tell you what happened, and we can go back and listen to what I said. I think it was I think what I said maybe didn't come across right, but if you listen to the specific words I said, particularly what I said was that I said the CMOs have had input in it, and we brought it to NEC. Then what I went on to say is that in policy is one thing, but in practice is another. And then I said I wanted to thank Dr. Yogel, the medical staff, for stepping up and participating in the decisions for making calls. So to the effect, I mean, I don't think it was a secret that the medical staff was not happy with this on-call policy. So did you think the medical staff was happy with the call policy in general?
No, I don't think so.
So, but maybe, to your point, and maybe it wasn't out there and everybody knew it, but I can tell you that I knew the board knew that the medical staff had issues with it. Everyone's commented on that it was an issue. Just from the joint conference, I think everyone expressed their concerns with it. So I didn't mean it like that, and I apologize if it did come across that way. But that's part of the reason we're bringing it back, is because we know that the medical staff did not buy into this. The CMOs were in every single call policy development meeting, and I don't know how many there were, because I think I got there halfway into when it was being developed. But yeah, I mean, it's clear there's issues with this that the medical staff have, for sure. So I think that's where.
And I'm not trying to throw Gino on the bus here.
No.
Because I think he's.
I heard that before.
No, I mean, honestly, I think, you know, I think I see in him, and I think my colleagues agree, someone who's really, really trying to make an effort to reach out and to right the ship, here, so to say, and reach out to the medical staff. There's no question about it, but there's just no question that I feel was misrepresented at the board and it was passed under those circumstances. But that being said, I appreciate the fact that they're backtracking and going back and saying, hey, you know, maybe we have to change this. The medical staff's not happy, and they're responding to it, and I appreciate that. But, you know, I can't go back on the fact that I feel that at the time, maybe misrepresent, I don't know if that's the right term or not, but I don't know another term.
Well, one thing that was music to my ear was the fact that he is too tall. I thought it was like Don Quixote fighting windmills, because he said it was not a CIA issue, because the CIA gets blamed for having a mouse in an office, okay? And so it was a business decision, and it took a carriage from his part. It's the first time that I've heard somebody mention that. So I just wanted to clarify that. Now there's another rumor mill out there. The other day somebody reached out and says Broward Health is going to get rid of all the non-employed physicians. I want to know if that's true, because that's the first time I heard of it. So you want to elaborate on that?
I might as well just pack up shop and go home if that's what we're going to do. That is not the intent.
Yeah,
the intent, there will be no one, literally. No, the intent is to build on utilizing our community physicians more than, I mean, this now speaking on a personal, I don't know if the rest of the executive team feels this way, but I think that going with large groups that are not community physicians to take care of patients that we have community physicians to take care of them, I think that's a problem. And there's certain areas where it makes sense and it works, but it's our fiduciary responsibility to make sure we do the most cost-effective thing. And if working with the community physicians and having more robust peer review to elevate the quality, if that's the way to get it done, that's what I'm going to support doing. So that requires community physician support.
Well, I just want to mention that the first dead person is going to be me, because I have about a dozen doctors in here. So if you want to get rid of me, don't do anything else, all you have to do is get rid of my doctor.
But you don't answer, Commissioner, to that, to your statement of the rumor mill that the doctors say, no, they're closing us out. I mean, that is the perception when people see this call policy, that initially, the perception is that call will be provided exclusively by Broward Health employed physicians. To me, what other perception can you have except that they don't want us, they want their own doctors? It is what it is.
Right, but you and Jim are talking, and we're looking at better days ahead of us, and this is why I committed, I serve on just about every committee here, and I committed to have as many of these meetings, and I know that we have lacked and been putting so many fires out, and this was one of those that we committed to realize that this is a very important group. And I offered, I said, you guys want to meet once a month? Hey, I'll be here. And I think we're in the right track now. But without communication, there's no entity that is going to move forward or get ahead or doing anything like that. Anyways, anybody else?
Yeah, one final question, maybe we can put this to bed.
Yeah. You hope so.
Hope so. Since it is a business decision, and since really the only facility affected, you said, is Dean Norris and the cardiology group, so there are, to my knowledge, 5 community physicians who now can't take call, who had been because they're employed physicians. Do you know what the cost savings is because now it's only employed physicians, and is that cost savings sufficient and warranted in light of all the ill will that it's creating? Are we really, if we're saving $100,000 a year or $80,000 a year, is it really worth it with the ill will that we're creating in the system?
I hope we're not that cheap.
No. So I don't know the answer to that. Frankly, it's a hard question to answer, even if I had the dollar amount, because if the community cardiologists were present here and doing work because they were on call specifically because of that, that would be a problem with giving them a call. In other words, again, it's back to the inducement.
Well, I can tell you, they haven't left. They're still there. They're not there because they had call. They're there because they've been there for years, whether they had call or not.
Is it worth the ill will? Probably not, but I think it's a bifurcated reason we did it. There is definitely a business decision there. We're paying for employed physicians. They should take call. And then there's a part of what can we do that's the most conservative approach. I wish that it affected no specialties in any of our hospitals. And I'm sorry it had to affect one hospital, one specialty, but I tell you, we're not looking to employ physicians unless they're community physicians who want to come on, because we have 1,900 community physicians and 100 employed physicians. So,
Alice, you might know, were the cardiologists even getting paid a per diem amount to take calls?
I can't answer that.
I'm not even sure they were. I'm not really sure you're saving anyone by excluding the community physicians. I think it's something that's important to look into.
If you're appointed, that cardiologists were not getting paid. There were some, if there was a mixture of a community physician and an employed physician, and the community physician was not getting paid to take call.
Might be worth looking into.
yeah, I'll look at it. I'm not even sure.
All right, so can we move on?
Commissioner, one final question.
Final question.
This is all about coming on call. You might know the answer to this. Under the last page, under removal from call,
Yes.
it only cites kind of breach of their employment agreement or coverage agreement. There's no bullet point to state removal could be from a peer process.
So, glad you asked that. So the employment agreement includes things within it that so for example, the peer process should be from a credentialing standpoint. The call process of removing them from call for quality issues would be because one of two things. Either peer review came up with something that they don't meet it, or they are not meeting the quality metrics in their call contract or within the specialty that was developed by the call management team. The only reason we would ever pull someone for quality reasons that were not done through peer review is if we were to administratively summarily suspend someone because they were immediate threat to life, which again, we would never do without the medical staff anyway. But if peer review wanted to go in and assess that there's a quality issue with someone, they could remove them from being able to take call by restricting their credentials.
You know, I have a question. If it's not a quality issue, but it's responsiveness and other factors, is that part of the criteria to remove them?
Yeah, so what happens is, and I won't say the name, but I'll give an example. Perfect example. We have someone who was on call at one of our hospitals in the last 2 weeks who, when the call policy was already in place. This individual was not an immediate threat to life, but they had response issues that were, this was really the second time it's happened, and they were unacceptable. It was a breach of the call agreement, and really didn't. So at that time, we said, all right, call management team, we need to remove them from call. So we got the chief of staff from the facility involved in practice, although hopefully in policy when it's drafted, it'll be in policy too. And they determined, yes, this is a response issue. We can't have this. This is really poor quality, and they removed from call the next day.
And does that need approval from the call management team? Does it have to get?
It does.
In other words, if through peer review, is one of the items in peer review could be recommended to Med Council is removing their call privileges?
Oh, no. If peer review comes up with something that's a quality issue because of them, what they would need to do is restrict their credentials. They could also make a recommendation to the call management team.
Restrict their credentials.
So in other words, let me say it the other way. The call is going to be, removing call based on quality is going to be up to the call management team solely, which should have the chief of staff involved in it. If peer review determines that they want to remove someone from call, the only way they could do that is, there's 3 ways. They could either summarily suspend someone, they could remove their privileges or restrict their privileges for something. So for example, if it's an interventional cardiologist and they take interventional cardiology call, they could restrict their interventional privileges, which would then, they wouldn't be taking call. Or they can make a recommendation to the call management team. So to answer your question, they couldn't just remove someone from call without going through one of those 3 processes. In the past, they probably could, I'm guessing.
Yeah, that's the reason why I ask is in the peer review process bylaws, that it's an option to remove them from call. And then where we have to get approval at MedExec, you know, from our peer gets presented at MedExec. And we could take somebody off call. I mean, it happened like 6 months ago we did.
So what we will do in that scenario, since we're in an interim here, because I think we need to change something to reflect one way or the other. If peer review, what is it based on peer review? Is it based on their quality?
Quality. Adverse out, yeah, quality.
So I mean, I guess I can say, the public forum, I guess I can say we'll honor, until we get this fixed up and it matches, we'll honor that request if it comes from peer review. I can't imagine we would ever disagree with that.
That has to go to MEC first.
Yeah. Through MEC.
So as long as you're, I mean, I assume we're rewriting this whole policy at this point, in the removal process, don't you think you'd be better off to include some kind of language in there that refers back to peer review? Again, talking about a patient safety issue and quality issue, but don't you think it should be included, that language?
So it should.
In some way.
And, so we did submit stuff back to peer review in that example I gave because it was necessary. We could probably add that in there because I think peer review should know that we're removing a physician for certain reasons.
I think you would be covering yourself. And from a JACO point of view, JACO is very concerned about patient safety.
I think it's a
They're
good idea.
most concerned. And I think, you know, to have it actually in the language somewhere in there, I don't know how you can write it.
Yeah, I won't. I'll somewhere else. Yeah, that's what we did, right? So I think we can add that in there. It's a great.
Will take consideration the report coming from the review process and individual answer to that.
See, Ms. Gino, you know, so MEC would then go to the call management team with this thing and decide if they'd be removed the call. You know, if you suspend some of these privileges, correct me if I'm wrong, that's important to the state.
Yeah.
So,
We don't want to do that. In fact, the only way you can do that is if it's an immediate threat to life.
understood.
So, I mean, I think it would be more what we're saying here. You'd make MEC, peer-reviewed MEC would make the recommendation to the call management team, and then we would.
And that wouldn't be reportable
No, it would not.
unless there was some other quality issue that kept
Right.
moving forward.
All right, should we move this on,
Yes.
so you folks can go home and have dinner? So we have
Contract update, just very quickly. I think you all know the contract process is a mess. We have 2 new leaders in that department. Alan, the CFO, has been leading a team for the last 2 weeks to completely re-engineer the process. The goal is to get a contract in and out and approved in 7 days. We are tracking towards that. We're starting that process by December 25th. We're going to shut the contract process down for 5 days to clear out everything in it. And then from that point forward, once we have everything in there, it'll be 5 days. 7 days, I'm sorry.
Really? This is music to other ears.
Oh,
Yeah, I think that, honestly, once you submit it, so it goes from 800 questions on the questionnaire to, how many, Kate? 8, Mike? 8?
It'll be about, the document itself will be about maybe 10 questions.
10 some questions. Yeah, once we get that, we submit
But
it.
it's also depending on that you get your information back, because the clock for 7 days doesn't tick until the
Once it goes in.
puts it into the queue, and that conflict of interest and all your disclosures are attached. So that's when the 7 days start.
It's going to save me about 30 hours a day.
let me go into new business. I do not want to lose my quorum and Commissioner Tanya for that soon, so do I have a motion to approve the October 26th meeting? Assuming that everybody read it.
I think there's a question on number 5 under new business on the on-call policy that I think Gino may have addressed. The first paragraph under discussion about the mandate by the monitor. Is that something you want to correct?
Where is that?
Page 2.
Page 2, number 5, second block in, second square.
The new on-call policy has been
So
made.
no, again, a new on-call policy has been mandated by the monitor.
Has been? I thought you said it.
They said we have to have one. They didn't say anything about what it had to look like or what it entailed. But maybe we want to add on there
System-wide might work.
system-wide, and we maybe want to add on there that the policy, because I said it, we may want to add on there, the policy was developed by legal compliance and administration, and there are certain components of it that are business decisions, and certain that we took from a conservative approach. Anything to reflect, what I just said.
And make sure that Dr. Jones
And that the medical staff was very supportive.
Better underline that. Yeah, underline that.
It's a joke, strike that for our
All right, so are we okay with these minutes now? Do I have a motion to approve? Okay. Yeah?
Where?
Yeah, second.
Second.
Okay.
Where?
Because I can see that. My ophthalmologist, she's with Broward all the time. I may be able to see next week. Anyway, that far. All in favor? Motion carried. Transfer reconciliations and out. Huh?
All of you, whatever.
Okay, so I basically called the person, I'll speak to us a little bit. In your packet is a transfer reconciliation slideshow, we'll pull that out for me. So as we're prepping for joint commission, we have found something we need to change within our system, and it affects the whole earmark of the whole system. Currently, basically our process is we reconcile medications only. That's the only thing that's required in the system. However, looking at Joint Commission requirements and CMS requirements, we have to reconcile all meds. And it makes sense, as you move a patient from one level to another, you need to look at all the orders, not just all orders, exactly. Not just medication orders, but all orders. So for example, what we found was we had some patients that had 3 diet orders. And that's because we're not reconciling orders other than medications. So we had Paul look at the system, try to make it as simple as we can to be in compliance, because we know we got Joint Commission shortly. And frankly, it's a safety issue. You can have orders that are redundant, that conflict with each other. So Paul has looked at it, he's made it very simple, but we want to run the slides by you guys tonight so you can see what it looks like. They're in the packet. We don't have a demo, but it's in the packet.
So before Paul starts, we actually, a group of us sat down with IT, went over these things several times to get rid of all the things that are either bad practice or otherwise patient safety issues. We cleaned up everything. Again, just clicking on medication reconciliation on transfer, everything now pops up in EMR and transfer location, diet, DNR, non-DNR status. It's an easy process, but again, it's a regulatory issue, so we have to do it. So, you want to?
The part that you guys want to look at starts on page 4. It has a little window with a little picture on it. In the Cerner EHR, you guys today, as they mentioned, are doing transfer medication reconciliation. So we're going to add in transfer order reconciliation. You follow the same workflow. So you go up to the top reconciliation, you click transfer. The next page shows you what you do today. Medications only show up. You flip over one more page. The new sections that have come along are all active orders. So anything that's completed, canceled will not show up, but all active orders will show up. And there are some of the sections there that show patient status, that show resuscitation status, to make sure there's not 2 on there. Vital signs, activity, nutritional services, so you can add 1 or 2 diets depending on the patient, what the patient needs, with some 2 feedings plus their oral feedings, radiology, etc. On the next page, it's kind of blown up a little bit more. Those resuscitation orders and everything, I just broke it down there. It's really the same thing that was on the previous one. So it's basically all orders. Several other hospitals in this area that are on Cerner have this implemented. I believe 10 hospital systems have. I don't know if anybody here goes to that. But it's been on, and so we're ready to turn it on. It's built in the system. You can't see it yet, but we're ready to go live once we start. One thing to remember as you're doing the transfer orders and reconciling and discontinuing certain things, if you're transferring to a higher level of care, obviously you're going to have to put your new orders in. On the last page here, the add order button is still there. You can add your new ICU power plan or whatever else you want to add from the power plan or single order.
Hopefully it's a simple because all orders in one column. The next should be continue orders. The third should be discontinue orders, right?
The first column where it shows, I don't have the color one, but it should be a green box.
Right.
The green thing, just like a medication. That order is all continue. The stop is the red square. We put there. And there is the select all. That was one of the things that was requested at the design committee meeting. So in any one section, for example, patient care, if you want to select them all to continue or to do a quick look and then just unclick one of them. Discussion.
I hope this goes through all MSCs and implemented the right way so that just not the primary physician, operating room surgeons when they transfer the patient, that will be itself. So make sure that all get, the transfer.
From an IT perspective, the design is done. It's an operational decision on how you guys want to force people to do. There's no magic button to force you to do it. You're going to have to go up to that top and click transfer, and then you guys can
So from the regulatory standpoint, there are only 2 places that you need to go when a patient is going to a higher level of care. So from OR patient is going to the floor, it's the same reconciliation process. The patient is going to ICU from the floor, we have to do the whole thing, which makes sense.
So from the OR to the floor, doesn't
It's the same reconciliation process you were doing. Now, correct me if I'm wrong, but now it is just going from lower level of care to a higher level of care.
It's surgery also. It's actually, that is, actually, I believe it's in the rules and regs.
Yeah.
So if you, I don't have a page number here, but it's the third page. If you look on the third page, this is pulled directly out of the rules and regulations of medical staff. So it does include surgery.
When we transfer the patient from ICU to the floor, we have to do this, if they call it 2 in the morning, then we have to do that at that time, or we can do it in the morning, the primary doctors.
That's really an operational decision on how you do that. But that's not a higher level of care.
No, from lower level.
You
from
continue with
ICU.
the same process you have.
Okay, just to the high level.
You're gonna, let me say this to you, you're gonna have to do it, and I'll tell you why, because you can't send them out on vasoactive drips or whatever, so you really have to do it.
So, at the same time, or can be done the next day in the morning, for example?
Well, there again, if you move them out, you've got them on drugs and things. Exactly.
No, the medications I understand, the rest. Usually, if they call at 2 in the morning, we need a bed in ICU, we need to transfer your patient to telemetry. Say, we go over the medications with the nurse, and the nurse does it for us.
Oh, she's doing it for you, you're fine as long as you got a nurse doing it, but you gotta have it in. Yeah.
So you have to, the rest of the orders, can be a lot of orders there.
There again, here's your problem. And I'll tell you this, we found it. We had some patients with 3 different types of DNR.
No.
DNR, full code, it's a problem. It's a safety issue. So in truth, you really should be having orders in.
Yes.
Can I make a suggestion from a simple-minded person perspective? Can you maybe have the IT, when it goes into the red box, why not just have a red circle instead of a green one again? You got green going all the way down on the red column. Can't you have red circles going down on the red column so that you can recognize visual recognition?
That's a Cerner issue. That's a Cerner coding thing, we can't change that locally, but I can log the idea with that, but I can't change that. That is a good suggestion, change that from dot to red.
Well, when's this gonna take effect?
Something you want to talk about?
You usually tie it to a role. We probably need to work the medical staff. I really think we need to talk to them first. So when is the next role?
Fourth Wednesday of January. I think for your joint commission.
I think if we're going together, I don't think.
26th or whatever it is.
I think that would give us plenty of time to work with medical staff. We want to work with you guys first. So would January, would that work? Would everybody work? Yeah. Let's do that. And we'll get the solves, ready to get on
Chip right.
There you go. I could tell you were never afraid.
Sandra,
I'll ask your wife about that.
so, can we move on from this item now?
Yeah, I think we got it.
Yeah, because I don't want to use my phone.
No, we're good.
So delinquent medical records,
Okay.
is that you?
Yeah. So very quickly, in the spirit of we want medical staff involvement in everything that we do, and we'd like to be on the same page with
I'd like to
everything.
hear that.
So, right now, CMS conditions of participation, 482, chapter 25. You guys know the rules, right? It's every 30 days, you can't have delinquents, right? So what it states is that final diagnosis with completion of medical records within 30 days following discharge. That's one of them, along with all the other things, the HMP within 24 hours, all that stuff, right? So we have in our bylaws right now, it states that how we handle the process is medical staff office submits a letter to, in writing, it says in writing, to the physician who is habitually delinquent. And then that person, if they want to reach out to the chief of staff and get an additional 30 days, they can give that. The issue is that it works for Joint Commission. This is one of the few examples where Joint Commission and CMS do not match. Joint Commission allows up to, they say they allow up to 50%, yet they cite you anyway if it's near 20 or 30%. In fact, we've been cited before. CMS allows 0 by definition. In practice, if you're less than 8-9%, they have not cited us as a past on full conditions of participation surveys. So, with that said, we need to have a policy for dealing with medical record delinquency. And what the industry practice is that really anyone who's over 30 days, that has charts over 30 days, gets a notice with ample warning, whatever that may be, at least a week. And when I say notice, I understand that there's opportunity for that because people either get an email to emails they don't read, or they get a letter that they never see. So we have a whole nother policy for that we can work on. I'm just talking about, let's assume it's perfect, right, for this policy. We need to be able to notice them, and then they have to come in and be able to provide, within that 12-day period, 7-day period, whatever we decide, they need to remedy. The one thing I want to point out, and you have the draft here, so we're not bringing this anywhere, this is for you to review. Let us know what your thoughts are on it, how we can add or subtract things from it. Okay, so we'll send it out to everyone. But what we need to eventually have a policy. One thing I wanted to point out, and I'll leave this for you guys to think about, is right now, the way that it works in the bylaws really has this sitting at the medical staff as it being their duty to suspend. The problem with that, and if you want to keep it that way, you can, but the problem with that is the National Data Bank. If you look at there was a Healthcare Quality Improvement Act, it defines professional review. Professional review is any action or recommendation of a professional review body. And then it goes on to talk about things. So the industry standard, and this is from the Medical Journal in Houston, but the industry standard is that hospitals suspend people from medical records administratively. Why is that? So that they don't have to report it to the National Data Bank. So I would make the recommendation that it's in medical staff's best interest to have administration with the medical staff. The medical staff office is the one that's doing it, but administratively suspend it and then have it sent to, if we're doing that multiple times, then send it to peer review. So it's up to you guys, but that's why I did the policy with that recommendation in mind. And then also keep in mind that if you were to do that, we would likely need to change the bylaws to match.
No, I agree. JCO regulation only talks about chronic delinquency. So that's what we have in our bylaw. So I think this is necessary. I mean, somebody who really tries to make phone calls to these folks, I think it's pretty hard to do those things. So I think it is necessary. But at the same time, I think the suspension thing, Amy, correct me if I'm wrong, suspending even through the peer review process, suspension for medical record is not a reportable. As an administrative event, even
through peer review.
I mean, it doesn't go to peer review. The chief of the department can actually act with HIM and suspend that position.
Then that is not reportable.
Yes,
it's not reportable.
Can we approve this policy?
MEC, your MEC, so in fairness, I was telling that most policies, I didn't intend to have you guys take an action to approve it. I was bringing it informational.
Oh, okay.
But you took action.
But you took action, which was fine. So I want to send it it didn't go to yours yet, right? So I wanted to send it to all the medical staff so they could provide the input and then bring it through the MEC, and then if the MEC is approved, bring it to the board. So the way I'd like to handle things in the future, if we can, if we have changes like this, I'd like to bring it to joint conference, explain what we're doing and why we're doing it, then send it to the medical staff so they can bring it to their individual MECs, and then get it approved by the board.
Change the bylaws. Yeah.
It would require a bylaws change.
I don't think we need to change it. We
Well, maybe
need
we
to
will.
add another paragraph saying a cure 30 days, because it only says chronic delinquency.
Giving the administration authority to suspend privileges of the position.
Yes, that's all it is.
It already has that in with post-op dictated note. That's already in the bylaws.
Yeah,
That's a joint commission requirement. That just needs to be enforced. And the RMOs has done a good job, but we whittled it way down, but not, we're going to need everybody else's input on it. They need to be done.
I think, I hear every day, I know this is for both parties. I see every day suspension letters from our institution. Absolutely, there's no effect. People get suspended, charged are still sitting there for even after afternoons, sitting there 30 days, 40 days, 2 months, 6 months. That's some deal to it. I don't think the way that we're doing, as a as a primary physician, I see that it's frustrating, surgeon that's an operating report, and I don't see it for a week. I don't know what happened to the patient. I mean, really frustrating. I think there's no truth. I know, at least for my institution, I don't know about your guys, I don't know how you guys do.
A lot of
You still
them,
see 30 days, 40 days, it's suspended.
in most places, if you're suspended, you're allowed to continue seeing your inpatient. You can't, is anybody else?
Nobody wants to take that.
So here, I'll tell you what just the premise of the policy to that point, because we have suspended people before and not taken them off. So what this policy does is, it removes your ability to admit or consult on anything new. You are allowed for continuity of care purposes to continue seeing your patients that are already admitted. So this puts teeth into it because you can't admit. And if you try to admit under maybe your partner's name, you won't be able to have access to go in and actually make any changes. We have that ability to sort of pull it. So this has some teeth in it.
But it allows for emergency. It does allow.
There's an exception for.
You
does allow for an emergency.
Well, no, because you won't have any elective surgeries allowed either.
If it allows for an emergency.
No. It would be whoever's on the call. Yeah, there's a caveat. If you only have one urologist in the whole hospital and they're on suspension, there's a caveat where, based on a need, we'll work with them not to suspend them. So, yes.
Folks, anybody wants to go home? Do I have a motion to adjourn? Happy holidays.
They put him on the suspension. Really?
January's new year, we can elect a new
No, in the north, when you don't build over, somebody's calling and saying, hey, we can dictate this. They call, that's when you need to call, right? It's for them to get on the phone and call.
They got put on.